Good morning. First, I would like to thank Dr. Krishna and Megan for allowing me to participate in this wonderful consortium, sharing and presenting our research regarding the confocal endomicroscopy and diagnosing pancreatic cystic lesions. As we all know, differentiating pancreatic cyst subtypes is a fundamental step for effective management of pancreatic cysts. However, our current standards of care modalities, namely cyst fluid analysis, are suboptimal in doing so. And this ultimately leads to high resection rates of low-risk pancreatic cystic lesions that can reach up to 60%. There are several novel diagnostic tools that are still underused in our clinical practice, and these include confocal endomicroscopy, cyst fluid molecular analysis, and through-the-needle biopsy forceps. Therefore, in this ongoing multi-center clinical trial called the CLIMB study, we aim to evaluate the accuracy of EUS-nCLE in differentiating mucinous versus non-mucinous cystic lesions and in identifying the specific subtypes of the pancreatic cystic lesions. A brief overview and background of nCLE. This is an advanced diagnostic tool providing a virtual biopsy of pancreatic cystic lesions in real time, in vivo histopathological imaging of the inner epithelium. And several studies in the past have demonstrated that it is safe, feasible, and more accurate than conventional methods in differentiating pancreatic cystic lesion subtypes. This diagram shows the nCLE processor that is connected to the endomicroscope mini probe, which is then loaded onto a 19-gauge needle. Once the needle is positioned within the cyst, the mini probe is extended beyond the needle tip to gently touch the epithelium of the cyst, allowing for the real-time in vivo endomicroscopy. And here's a stepwise approach to diagnosing pancreatic cystic lesions using nCLE. The first step is to detect the presence of papillae, or epithelial bands diagnostic of a mucinous cyst. And papillae, as we can see here, are finger-like projections with a vascular core, and this is typically diagnostic of IPMN. On the other hand, epithelial bands are flat and are seen with MCN or with IPMNs with low-grade dysplasia. The next step is that if these patterns are not seen, the next step is to look for the trabecular pattern where there are nests of cells that are separated by the stroma of the cyst, which is diagnostic of cystic and neuroendocrine tumors. And if these epithelial patterns are not present, then you look for a vascular pattern with a dense capillary network. This is called the Fern pattern of vascularity, and this is consistent with serous cystadenomas. Lastly, if none of the vascular patterns or epithelial patterns are observed, and the image is simply a dark background with the bright autofluorescent inflammatory cells, this is most suggestive of a pseudocyst. As mentioned, the CLIMB study is an ongoing multi-center prospective clinical trial since 2018, involving 14 U.S. tertiary centers and 17 endosonographers. And as of November 2024, the study has enrolled a total of 422 participants, 187 of which have a definitive histopathological diagnosis, and 136 of these participants have NGS results. All of the EUS-nCLE patterns were interpreted and documented in real time by the performing clinician during the index procedure. We then analyzed the nCLE accuracy for differentiating mucinous from non-mucinous pancreatic lesions and compared it to both NGS and standard diagnostic modalities such as cyst fluid glucose, CEA, and cytology. Regarding our results, of the 187 participants, 63% were females with a mean age of 63.5 years. About 51% of the pancreatic cystic lesions were mucinous in nature based on histopathology. And these cystic lesions were actually on the larger side with a mean diameter of 4.2 centimeter. And 82% of our patients and participants had at least one worrisome feature based on the Kyoto criteria. This table shows the diagnostic performance of EUS-nCLE, cyst fluid analysis, and NGS in differentiating mucinous from non-mucinous lesions when compared to definitive histopathology. And cyst fluid analysis is defined as either cyst fluid CEA that is more than or equal to 192, and or cytology revealing mucin, or cystic glucose that is less than 50. And as we can see here, the diagnostic accuracy of EUS-nCLE was 95% in comparison to cyst fluid analysis and NGS, which were 83% and 76% respectively. It should be noted that the NGS practices have varied among the participating institutions. using different assays in accordance with their institutional policies. And this may explain the relatively lower diagnostic performance that we can see with this diagnostic modality. This table shows the high diagnostic accuracy of EUS-nCLE in differentiating the pancreatic cystic lesion subtypes. And as we can see here, all the metrics were exceeding 90%. From an adverse event standpoint, nCLE is generally a safe procedure. However, as per the most recent update of the CLIMB study, there was a 3% risk of post-procedure acute pancreatitis, all of which were mild in severity, and there was less than 1% risk of intracystic bleeding that did not reach clinical significance. None of our participants had any reported infections. In conclusion, this is the largest US-based multi-center clinical trial to date that illustrates the high diagnostic accuracy of EUS-nCLE for differentiating and diagnosing specific pancreatic cystic lesion subtypes. This high accuracy was consistent among multiple operators, supporting its broader use and its potential for integration into our diagnostic algorithms, especially for larger cysts more than 2 centimeters. Lastly, I would like to thank our participating sites and their respective study investigators for their collaborative efforts in advancing the management of pancreatic cystic lesions. Thank you very much for your time.
Good morning. Thank you again for the invitation. It's really an honor to speak here, and it's a little bit of a different type of talk and different type of title that I was given, Cysts 360, which I had to think about what that means. But the way I sort of interpreted it is to kind of give a little bit of an overview of what I could gather are areas of sort of where we need more data and more research, kind of divided into 360 around pancreatic cystic lesions, focusing on diagnosis, risk assessment, treatment, and surveillance. Not going to present a lot of data as much as sort of think about some of the things where the focus is, and a lot of the exciting developments in this area we will actually hear about today. So I think just in terms of diagnosis, I think some of this we know, perhaps some of this we don't recognize. It does seem like the prevalence of pancreatic cystic lesions is increasing. This is in a large real world study we did a few years ago. It actually is outpacing the rate by which just simply imaging-based diagnosis would predict. There are still very limited non-invasive biomarker tests, and the diagnostic burden, as we all know, is very significant, both from a financial and patient anxiety standpoint. About 15% of cancers that are ultimately diagnosed are IPMN based, but I think it's important to sort of zoom in on the fact that, of course, the majority of these cancers that are ultimately diagnosed as IPMN based were not enrolled or even considered to be in a screening program. So although there is that opportunity to screen for these patients, we miss this opportunity in most of the patients we ultimately diagnose. On the other hand, as I think everyone in the audience knows, despite our best efforts, we're still doing much more surgery for these cysts than we should. I think in the field there is a real need to define the true prevalence and natural history of these lesions. And as we have more and more sort of EPIC and electronic health record based machine learning powered methods to really identify all cystic lesions, I think that will be something that we will see. Clearly, the other area is enhance our non-invasive diagnosis. And I kind of purposefully will not talk about maximizing EUS-based diagnosis for sort of cyst type identification, because this is, of course, something that we will hear about and have already heard about a little bit earlier today. I think this is just 2 quick slides of areas that I think are exciting and we should take we should develop. This is machine learning powered electronic health record based identification of patients at risk for pancreatic cancer. So this is one of the models. There's at least 4 or 5 of them. This is the one we built, and now we're starting to use. What it does is it identifies you based on single variables in the electronic health record, single diagnostic codes, identifies patients who are at risk for pancreatic cancer. You can get a blip of signal in the EHR that says this patient may be considered for pancreatic cancer screening. And interestingly, having a cystic lesion is part of it, but many other variables are. It's a way for us to really find every patient who we may need to consider for screening. This is the other sort of part of the future, which is AI-based diagnosis in radiomics. This is a large study called the CystX Consortium that we have participated in, and that really has developed an entirely MRI-based, now automated segmentation and diagnosis approach to identify and categorize cystic lesions, both for severity and for cyst type. And this is a large database that's actually now made publicly available, and that we're continuing to mine to be able to offer non-invasive diagnosis. What about on risk assessment? So to a large extent, we're still kind of at this stage where we use variations of the different guidelines to essentially classify patients based on imaging, a few symptoms, and a few laboratory tests into being high risk and low risk, and kind of use EUS in the intermediate risk category to further stratify patients. How can we do better? So we'll hear a lot about this today, but I think the message today from this slide is that on the cyst biomarker side, I think what is clearly emerging is that we have to use sort of a multi-omics approach. Next-gen sequencing was a really important and significant advance, but alone it will not be sufficient to provide diagnostic accuracy. And for that end, we need methods, especially from cyst fluid analysis, that requires smaller and smaller quantities of DNA, RNA, and proteins. The little graph on the right is our first attempt at using a 100-fold lower DNA amount-based sequencing methods called this TAPS-based sequencing, which provides genomic and epigenomic analysis for cyst fluids and may have a significant promise. And of course, at the bottom are the AI strategies, both for, as we will hear about, for confocal microscopy to diagnose or risk stratify pancreatic cystic lesions, and also sort of global EUS-based imaging AI methods. So treatment, I think this is where I'm most passionate, and I know many people in the room are, to really try to take this away from being a surgical disease, especially given the fact that we're treating in the majority of cases a pre-malignant lesion with significantly morbid surgeries to this day. And the really two modalities that have emerged, this is an older slide, sorry, I didn't realize I didn't send the updated slide. But the two modalities that are emerging as really significant, and we'll hear about them, are chemoablation strategies and radiofrequency ablation for cystic lesions, which are both becoming safer and through the studies are proving to have a significant efficacy with sort of complete resolution of cystic lesions upwards of 70–80%, which is really, I think, a very important target when we're treating a benign disease. But most importantly, these methods are also proving significant safety profile without major adverse events. I'm not going to show that. Just this is well, I'll just comment on it. So in our center, and I think perhaps in some of yours, and this may be a bit of a debate at the end of this, we actually have a kind of algorithm of how we non-invasively or non-surgically treat these patients. And I think this is something we will have to evolve how we choose between ablative methods versus chemoablation to treat cystic lesions. And then finally, on surveillance, I think this is obviously where we spend a lot of, if not most of our efforts. This is a sort of summary slide from a recent review we did, which kind of compiles all of the different guidelines, and it's a size-based surveillance recommendation, but we still don't know when to stop surveillance and how to really reduce the burden of surveillance and how to reduce the cost of surveillance. The one thing that I will emphasize here that we're very interested in, I know many people in the room are interested, and we're starting to do, are focused imaging, which takes from an abdominal MRI to a pancreas MRI that can take in our center now up to no more than 10 minutes to complete. And I think that will sort of change the landscape of how we survey these patients. Obviously, non-invasive biomarkers are an important part of it. And I think finally defining who are the patients that we can safely stop surveying is very important. That's all I had. Thank you very much.
Everyone, it's a great honor to be here. So I'm going to talk about the EUS-guided ablation for solid lesions. As we know, in pancreas cancer, survival truly depends on the stage. Most of the patients unfortunately diagnosed at a later stage of disease, so survival is very poor. Very recently, there is a transatlantic pancreatic surgery consortium that highlighted that not just your resectable anatomy, but even patient's biology and condition actually impacts the survival. So you can have resectable patient with poor biology or poor functional status, and immediately survival goes down. And this is probably some type of criteria we need to be using. When we look at treatment options in pancreas cancer, chemo and surgery are the standard of care with the radiation as a palliation role. Recently, targeted therapies are emerging, but I strongly believe that EUS-guided therapy has a role in treatment of pancreas cancer. Last year, I presented some of our work in a mice, but what lessons we have learned from our mice experiment is that when you do radiofrequency ablation, it actually remodels tumor microenvironment. It activates body's immune response and causes T-cell infiltration in primary tumor as well as distal tumor. RFA does cause abscopal effect in distal metastasis, and repeated RFA is actually more effective than a single RFA treatment. And post-RFA, there is higher expression of PD-L1 in both primary as well as distant metastatic site. And this can give you therapeutic options that you can combine RFA with PD-L blocker. And there are also other immune checkpoint inhibitors you can use post-RFA. From this thing, we had a couple of trials currently ongoing at UT. So PanCardinal 1 trial is an NIH-funded trial where we have resectable patient undergoing neoadjuvant chemotherapy and RFA. And we have also a EUS-RFA prospective registry where we have enrolled patients with all stages of disease. So we currently have 35 patients in our PanCardinal 1 trial and over 100 patients in prospective registry. To date, 550 RFA procedures been done. This is the protocol in a PanCardinal trial where patient undergoes standard of care chemotherapy on a neoadjuvant setting, and we do repeated RFA at week 4, week 8, and week 12. And after that, if patient's resectable on a CT scan, they go for surgery. I'm going to actually show you the data from our prospective registry. We finished enrollment about 6 months ago, so we have some of the survival curve coming out from all the patients. So we have 38 metastatic patients treated in the prospective registry, 24 locally advanced, 9 borderline resectable, and 10 resectable. Out of them, 40 had less than 3 RFA, 41 had 3 or more RFAs. Some of these metastatic patients, we actually did give immunotherapy on top of RFA. So if you look at the data currently we have in a resectable cohort, 10 patients, median survival is 68 months. Borderline resectable, I do not have median survival data as of yet. Locally advanced unresectable survival is reaching 22 months, and in metastatic group survival is 17 months. And if I further break it down in the metastatic cohort, those who had less than 3 RFA survival was about 8 months, and those who had more than 3 or more RFA survival was close to 24 months. So again, kind of proving the point that with repeated RFA, we can significantly improve the survival. All these data are better than SEER registry or our internal cohort at UT, that if patients had only undergone just a standard of care approach, the survival data, this data is much better, and we are very excited with this results we are seeing. We do see very good abscopal response. So this is one of the patient, pancreas cancer, large metastasis in the liver, only received ablation at a pancreas cancer, and in a follow-up CT scan, tumor continued to be smaller, and 1 year later, there is a barely recognizable tumor at the same site. Looking at the pathological response, of 17 surgical resected cases, in 14 patients, we had seen good pathological response. 1 patient had a complete response, and 3 patients had a near complete response. If you look at the post-RFA complication, about 30% of patients do have post-procedure abdominal pain, nausea, and vomiting. This is usually self-limiting and does not need admission, so most procedures are done in an outpatient setting. GI bleed requiring blood transfusion or repeat endoscopy in 3 cases, mainly secondary to the ablation effect at the duodenal mucosa. We have changed our protocol, learned through the procedures what not to do, and subsequently our rate of GI bleed has gone down tremendously. I had 1 case of duodenal perforation when I did RFA through the metal stent, and RFA energy essentially went through metal stent at the site of ampulla, and that caused the perforation. So now if I'm going to do RFA, I just keep the plastic stents and I do RFA around the plastic stent. If you have impending biliary stricture and you do RFA, then you are at a risk of biliary stricture. So if you're going to do RFA close to the bile duct, probably a good idea to actually have a stent in. Now I'll switch the gears and also talk about EUS-RFA for non-functional PNET. Thomas led this study. So this was a multi-center US consortium where 7 centers enrolled 46 patients with a pancreatic neuroendocrine tumor. Most tumors were less than 3 centimeters in size. After initial RFA, we did the assessment at 3 months via EUS, MRI, CT, or PET. And those who were partial or non-responder, we offered additional EUS. And our maximum follow-up range from 3 months to 16 months. And if you look at maximum follow-up, we achieved complete response in 55% of patients, partial response in 21%, and 18% of them were non-responders. Thank you. I have to run, but these are my contact information. Anybody has any questions, happy to answer that later on. Thank you.
Well, good morning. I have the pleasure of being the lone surgeon in a room full of gastroenterologists. So it's a distinct pleasure to be here. Thank you for the invitation. So this is a very common clinical scenario. These patients are in my clinic. They're in most of your clinics and our primary care doctors. These are patients we see every day, every week. And it's going to continue to be a major problem for us as the incidental pancreatic cystic lesions are increasingly detected on cross-sectional imaging with prevalences ranging from 5 to up to 20% and probably even higher on autopsy series. Now, on the other hand, pancreatic surgery is very morbid. We like to joke that pancreatic surgeons really just do 2 operations, a pancreatic duodenectomy and a distal pancreatectomy and splenectomy. Now, to be fair, we probably don't quite give ourselves enough credit. Occasionally we can do a pancreatic enucleation. Of course, we can do a total pancreatectomy, and every once in a while we will preserve the spleen when we do our distal pancreatectomy. And nowadays we do all these operations, both standard open fashion with a laparotomy incision, and of course we do all these minimally invasively, most often robotically at our institution. But regardless of approach, pancreatic surgery still has significant short-term morbidity. Mortality has decreased over the past several decades, but morbidity continues to be a major problem. So this is some of the most recent data from the American National Surgical Quality Improvement Program. So this is 30-day morbidity nationwide, specifically for patients who had Whipple's for pancreatic cystic lesions. And this shows a mean length of stay in the hospital of 8 days, major complication rate of 20%, a 30-day mortality rate of 1%, 10% patients are discharged to a non-home facility, and 20% readmission rates. And these rates are probably even slightly higher if you look outside the United States. This is a prospective study from a registry study from Germany. Again, pancreatic resections for cystic lesions. And here they had a mean length of stay of 15 days, major complication rate of 28%, and mortality rate of 2.6%. And if you extend, probably a 90-day mortality would be a better metric to look at, or other patient-centered outcomes. And these rates of complications, morbidity are probably even higher. And of course, there's long-term morbidity as well. So this is a study from our group from a few years ago, which estimated that there's an approximately 20% risk of new onset diabetes following partial pancreatectomy, specifically performed for pancreatic cystic lesions. And rates of exocrine insufficiency may reach as high as 50%. And of course, there's our long-term morbidity, chronic pain, GI dysfunction, hernias that come with pancreatic surgery. So despite all of those risks, both short and long term, the rates of resecting benign pancreatic cystic lesions continues to persist. So this is a summary of relatively recent surgical series that looked at the proportion of resected patients that had serocystadenoma, with rates ranging from 6 to 15%. And when you look at, again, relatively recent surgical series at major tertiary centers of patients who've had resected IPMNs, rates of low-grade dysplasia in their pathology range from 40 to 63%. And so this supposed over-treatment has really persisted over time. So this is a paper, it's a little bit out to date now, that showed that the proportion of pancreatic cystic lesions with benign pathology has remained stable between 2002 to 2012, despite advances in endoscopic technology, despite evolving guidelines to try to limit and be more selective in surgery. And this is an updated analysis just from last year, which again shows a very similar trend, that the proportion of resected patients with 4 cystic disease and among cystic patients with benign pathology has really not changed over time. So in summary, practice patterns in the treatment of IPMN, of all pancreatic cystic disease, has not changed significantly in North America. And of course, we always need to balance the risks and benefits of these approaches. The risk of missing a cancer, of course, and balancing that with the short and long-term risks of surgery. And it's exciting to learn about all the advances this morning. But I think, one thing I would conclude with is that we know that surveillance of most side branch IPMNs is initially safe. So I wanted to conclude with some real-world data. This was just presented last year at the American Surgical. This is basically a 3-decade experience from Cleveland Clinic, in which they have emphasized a multidisciplinary approach, emphasizing active surveillance, at least initially. So they looked at approximately up to 3,000 pancreatic cysts over 3 decades that were evaluated by surgeons. And after excluding non-IPMNs, patients who had upfront surgery, a small proportion, and those without at least 6 months follow-up, they studied the outcomes of 1,000 side branch IPMNs. And they found a 15% risk of clinical progression during active surveillance. They define that as growth greater than 2.5 millimeters per year, development of symptoms, or solid nodules or invasive carcinoma. In that 15% cohort, 86% were offered resection and 39% underwent resection. And overall, they found in this 1,000 patient cohort a 1.7% incidence of invasive carcinoma that occurred at a mean 6.7 years later. And interestingly, more than half, the majority of those patients that developed cancer, were in a location of the pancreas other than the cyst. And then finally, they found that among patients who had clinically relevant progression, surgical resection was associated with improved survival, but surgery was not associated with improved survival among all comers. So again, the overall conclusion from this single institution experience is that a strategy of initial active surveillance is safe and potentially advantageous. So thanks again for the opportunity to speak. To conclude, pancreatic surgery continues to have short and long-term morbidity, and the rates of benign pathology in pancreatic surgery specimens continues, and it suggests some degree of continued overtreatment. And of course, we all look forward to novel diagnostic techniques and refinement of guidelines to improve outcomes for all of our patients. Thank you very much.
Good morning, everyone. I'm Jorge Machicado from the University of Michigan.
Now we're going to switch gears, and during the next 3 talks, we're going to talk about endoscopic treatment for pancreatic cysts. Now, specifically, this talk will be dedicated about chemoablation for branch duct IPMNs. These are my disclosures. When we talk about endoscopic cyst ablation, we have to recognize that initially we started doing this with chemical methods. So we use dehydrated ethanol, and the first publication of this was about 20 years ago by the group of Bill Brugge at MGH. And what they noticed, and multiple studies were replicated, is that the cyst resolution was only 1/3 of the patients who were ablated had a resolution of this. But if you see, there was a 22% rate of adverse events, which is unacceptable. And many of these were pancreatitis, patients experiencing pain, being admitted to the hospital afterwards. Then the field started moving towards using chemotherapy agents and different types. And the cyst resolution with this was about 2/3 of the patients would get a cyst radiologically resolved. We don't know if histologically it is. And of this initially was done in addition to ethanol. And when this was done, the adverse event rate was 15%. Now, when ethanol was removed from this mix and it was just left with a chemoablation, you would get still a similar cyst resolution, but with 0% adverse events. The field is moving also towards radiofrequency ablation, where there's emerging data with a cyst resolution similar with chemoablation, about 2/3 of the patients, with some degree of adverse events. But I think that there's a lot to continue learning about the radiofrequency ablation methods, and Som is going to touch upon that part. And when we think about who is the ideal candidate, I think that it's important to recognize that not every cyst is the same, and that we need to personalize the management that we have for these patients. First, of course, we need to recognize which patients have IPMNs. And for that, we have to become experts in utilize all the methods that we have available, nCLE, molecular analysis, through the needle biopsies when possible. Now, when you select these candidates appropriately, then morphologically, really you have the advantage to kind of personalize who would be a good candidate for chemoablation. And the principle is that you're really putting volume and replacing the volume of the cyst within the cavity of the cyst. And in that setting, really unilocular cysts are advantageous for that purpose because it can distribute pretty well within the cyst. And the studies have really enrolled patients between 2 to 5 centimeters. Now, can you go off that and do more? Possibly, but you're going to take a lot of more drug, and there's limit in the amount that you can put. So that's when you can personalize probably and consider a different method rather than the chemoablation part. Multilobulated cysts that are communicating within each other can allow that drug to distribute properly within it. And if you get like septated lesions, if you have maybe 2, 3, up to 4 compartments, that would be an ideal situation in which you individually put a needle into each of these cyst compartments and inject the chemotherapy. But if you do it into lesions that have more compartments, it's going to be very, very challenging that you can distribute the drug, and that's a limitation of chemoablation. Now, shared candidacy with other ablation methods include, if patients have a low life expectancy, less than 3 years, probably it's not going to be a good candidate for doing any sort of endoscopic chemoablation method. The inability to safely undergo a procedure with anesthesia, of course, should put us under thought. And if there's suspected or confirmed malignancy, those patients probably are not gonna change the trajectory of their disease by doing chemoablation. This is a list of the studies that have looked at chemoablation combined with alcohol. And you can see really that one of the things that are in common is that the type of cyst that they treated is not homogeneously for branch duct IPMNs. And that's because the studies were done at a time that we didn't really have the methods that we have currently to select what candidates really can undergo these therapies. But what strikes in this table is that 2/3 of the patients, really a range between 50 to 79%, had complete resolution of the cyst with chemoablation plus alcohol. But the problem is that with the alcohol, as I mentioned before, all these studies had some degree of acute pancreatitis and definitely post-procedure abdominal pain. So for that purpose, the CHARM trial that was published almost 8 years ago now evaluated the combination of paclitaxel with gemcitabine with alcohol or without alcohol. And in this single-center, double-blinded, non-inferiority trial, they included cysts that were mucinous or indeterminate, that were between 2 to 5 centimeters, but really the mean size was 2.5 in this cohort. And they evaluated complete response that is defined as more than 95% reduction in the cyst, partial response between 75 and 95, and non-response less than 75. And I think that these are important as we evaluate our programs and we have definitions that we can use homogeneously between the trials and we communicate among each other. So in this study, they found that there was a complete response rate with or without alcohol in the range of 60 to 70%, with a cyst reduction overall of 80%. And only the group of that received ethanol had a risk of adverse events, included 6% of pancreatitis and 22% of post-procedure pain. And this was eliminated when alcohol was removed of the equation. So currently, if we're going to be doing treatments with chemoablation, probably alcohol shouldn't be in the mix, given the increased risk of adverse events. Now, when they look at the long-term outcomes of doing chemoablation within this same cohort of the CHARM trial, they published this a few years ago of the 36 patients that they had a long-term follow-up at 3 years. They found that 87% who had achieved complete response maintained the response at the 3 years. And it's important because we're starting to get now long-term data of all the things that we can do with chemoablation. And 31% with no response or partial response, then even were able to have a complete response over time. So in other words, even if you follow them at 1 year and you don't see a response, over time you may still see a response of the effect of the chemoablation. And none of the patients in this cohort had high-grade dysplasia or cancer. The same group also published recently their 5-year follow-up, and they conducted models just to evaluate the cost effectiveness of being in a protocol of the CHARM trial, in which they would do an MRCP at 1 year and 2 years, and then annually for 3 to 5 years, but could go to every 2 years if there's a complete response of the cyst. And they compare it with the Fukuoka ACG guidelines, and even a Fukuoka guideline if the cyst was small. And they found that by doing chemoablation, you are really decreasing the frequency and the amount of surveillance on these patients. Now, aspects that haven't been measured are, for example, the stress and anxiety of the patients that frequently we see in our clinics, and they really don't like going through this surveillance process and knowing that they live with a cyst and with a risk of pancreatic cancer. Now, we don't know, of course, if this technology decreases the risk of pancreatic cancer or not at this point, but I think that that long-term data is what we need to understand this technology better. Now, I'm going to switch gears now about how to build this in our practice, because we have the data. Now, I think that the question is, are we convinced or not whether or not to do it as part of our clinical practice? The first part is having the stakeholders. I mean, some places, the surgeons may not really favor this type of treatments, but many places, they are really on board with it. Like our surgeons, we talk to them first, and they want patients to get the treatment with ablation. They're often sending patients out. And, if you think about the treatment, if there's a problem and the patient progresses or the cyst is not resolving, you can always salvage that with surgery. And the surgeons are very favorable of that option. Now, of course, you want to work with your oncology group, with endoscopy unit leaders and staff, because you're going to adapt something that is very different. I mean, we're used to using devices, RFA, and setting up other things can be easier. But bringing a drug from the oncology chemotherapy space into the endoscopy unit can be completely different. Working with a pharmacy, working with patients, and understanding what are their needs within your practice is all important. Now, when we think about how to work with your endoscopy unit, you want to involve the nursing manager, the nursing educator, and the endoscopy chief early in the process. It's important that they apply to get chemo certification. So there's going to be some steps that they have to go to have the unit prepared and ready for that they have the proper bench, that they have all the equipment to get this ready. They don't need to save the drug in the endoscopy unit. You can bring that from the pharmacy during the same day. There has to be a process for safe handling and the disposal of the agents. In addition to that, you want to assemble a chemoablation team. That's really important that you have like 1 to 2 dedicated nurses and techs who are working with you frequently on doing this type of procedures and that they become experts on this. And the staff is going to require doing some chemo certification, but at the University of Michigan, at least, we had like 5 to 6 that immediately signed up. They were very motivated. They want to get started because this is novel, and they feel it can help patients, changing their life or decreasing the risk of cancer. Now, the supplies that you're going to need, the ablation, at least that we are now most commonly doing, is the combo of paclitaxel with gemcitabine using data from the CHARM trial. Other centers in Asia are using only paclitaxel, but there can be a problem with how the density is of the drug. But with a combination of both, the density seems to be more favorable and it goes easier when you're injecting it. And we want to use up to 25 mLs, and that's based on guidance from the FDA for the CHARM trial, because that's the limit that is used for HIPEC. And you want to use a 30 to 50 ml polycarbonate syringe because that allows the drug not to accumulate and to go easier. You want to have a high pressure infusion tool. This is the same that you use when you do dilation balloons. And it's preferable to use a 19-gauge needle because the drug will go easier into the cyst as compared to a 22-gauge needle. But you can use a 22 sometimes in the on-synate process or pancreatic head. Now, how to order the chemo? Really, you need to partner with the pharmacy and with the oncologist. You want to put an order a few days prior of doing a procedure. With 24 hours in advance, the pharmacy can pretty much prepare everything and be ready to go for the next day. You want to work on the instructions of how to prepare the cocktail. There's instructions set up from the group of Matt Moyer in Penn State that he has been very generous to share with us, for example. And you want to partner with people who have been doing this for some time so they can help you setting up your chemoablation program. Now, the hardest part of this, to tell you the truth in our experience, is how to implement this from the pharmacy perspective. We, as gastroenterologists, are not used to work with chemotherapy. And of course, we do a lot of things off-label in interventional endoscopy, like RFA and other things. But this is a totally different thing to work with. The first thing is you need to be convinced that this is going to work for your patient and you are offering it for clinical purposes. And this is if you are going to implement it clinically. You can talk with your local FDA expert and ask if an IND approval is needed. You want to connect with non-oncologist MDs who give these treatments frequently, like, for example, interventional radiology or interventional pulmonologists. We connected with them, they share their experience, and that helped us a lot. There's a procedure billing CPT code for this with a US 5-needle injection. Now, the chemotherapy and clinical pharmacy, there may be an insurance that can pay for it, but sometimes it can be out of pocket. But now you have to think about that the chemotherapy that we use is really not that expensive. So it can be like about $200 or so for the drug, plus the use of the clinical pharmacy. Now, this process took a while for us to get there. We talked to a lot of leadership members from the cancer center, from the pharmacy, from different people to get to the right individuals that could help us. And at the end of the day, is the leadership people in the pharmacy of the cancer center that you work on that can help you the most. So if you are thinking about this, those should be people that you involve early on in the process. Now, the alternative route, instead of doing it from the clinical side, is going the research side of it. And for this, you're probably going to have to submit it to the regulatory board. You may need to submit an IND. This can be very cumbersome and long process to do. And especially it can be very challenging because then you're working with the oncology IRB, and doing this type of treatments can be a little bit more challenging. The IND submission is about $5,000, so you're going to need donors and money. For example, we got some donors that could help us potentially to build up this program if we need it from the research side. And again, because patients are just so interested to getting this off the ground that they were willing to pay and donate for money to get this done. But at the end of the day, I think that you have those two options: either go through the clinical pharmacy, and if they allow you to set up the program, it can be very helpful to do it that way. But if not, the research pathway as a feasibility trial or pilot trial can be a good way for you to get started with a program like this. Finally, just about the technique, you can do it with MAC anesthesia. When you do this, you want to aspirate entirely the cyst fluid, leave a rime of mucin fluid within it, and then you want to measure exactly how much you extracted of the fluid, and then replace it with the chemotherapy cocktail that you have. Again, no more than 25 mL in total. And then you want to reconstitute this to the original size and dimensions that you had. That's typically guided by the volume that you had and by the endosonography images. And then you want to repeat this to every compartment. I mean, you're going to be able to see, as in the figure, where the cocktail is really going. And if you see an area that hasn't really received the treatment, then you want to repeat it during the same session in that area. And then afterwards, you want to follow up patients in 3 months, and it can be repeated at that point 1 or 2 times prospectively. If you want additional resources to learn the technique and how to set up a team, Dr. Moyer has put together in GI Lib and also in HSGE, GIE, some resources that can be very helpful. Thank you, everyone, and I want to thank my team at the University of Michigan and Dr. Carpenter, who has worked with me setting up this program.
So changing gears to EUS-guided radiofrequency ablation of pancreatic cystic lesions, the other modality to ablate lesions. So currently there is just one FDA-approved needle and generator available for pancreatic RFA. For treating IPMNs, we typically use the 10mm probe, since these lesions are often larger and require a broader treatment zone. And here is the equipment on the slide. So here is a checklist. It's a detailed checklist, 3 compartments. You have medications, setup and equipment, and documentation. All patients do get prophylaxis against pancreatitis with rectal indomethacin and ringus lactate. As far as the equipment goes, the ice bath is the most critical aspect. Get the ice right before you want to do the RFA, because the ice will start melting. The power settings for this are 50 watts. And again, that's something which has to be standardized under a continuous mode. And make sure the grounding pads are placed properly. The most critical aspect is documentation. You document, we strongly encourage doing RFA on a clinical trial basis. So you document every aspect of the ablation, the amount of fluid you're going to aspirate before ablation. You record the number of ablations and how many of them reached impedance, how many of them maxed out to 45 seconds, and also the total duration of RFA. In terms of the technique itself, it's again into 3 big compartments. You have aspiration, which is aspirating the IPMN. Now, when you would have performed the first EUS-FNA, you will know the viscosity. So document the initial viscosity, have a personal note on the patients, like a typical EPIC. You can have the yellow sticky note. You can have personal notes, how the approach was, how viscous the fluid was, how much time it took you to aspirate. Based on that, you can use a 22 or a 19 gauge needle to aspirate the IPMN. Subsequently, we have a video coming up in the next slide. Subsequently is energy delivery. You're going to deliver energy up to 400 ohms, which is the
peak, which impedance which you stop delivering, or you time out till 45 seconds. Now, the critical aspect is to examine this by EUS and also by endoscopy. Now, what we didn't realize initially was that we did not do a follow-up endoscopy after ablation, and soon, we had complications. So at the site of entry of the needle, you can have an ulcer, and if the patient is on an anticoagulant or antiplatelet drug, they can come back with bleeding. So it's important to examine that area. If there's a shallow ulcer, put them on PPI for a week or two, and have a 3-day lag before they start antiplatelet drugs like Plavix. So here are 2 videos, and again, for the sake of time, I'm going to play them in parallel and try to walk through the video. Here are 2 IPMNs. One is septated, one is fairly unilocular. The first step is you aspirate the cyst. You identify critical structures around that, and you start aspirating the cyst. You don't want to aspirate too much because you want to have a sufficient target for RFA. And once you aspirate, you introduce the RFA needle, and you proceed from a distal to proximal direction where you will start doing RFA. So once you start doing RFA, the timeout for each application is 45 seconds if you don't reach peak impedance. The peak impedance is about 400 ohms. So once it reaches about 200, 300 ohms, it's going to quickly spike to 400. So you have to be on the ball right there to press to shut it off. So once you start doing RFA, you will see these white bubbles, which is basically tissue vaporization, small gas bubbles. The white bubbles do not mean much. That's not the reason to stop RFA. You're still going by the, either it reaches 400 ohms or whether you time out till 45 seconds. Generally, if you have more fluid, it's going to go all the way to 45 seconds. If you have less fluid, you're going to get an impedance spike. So you go from a distal to proximal location. And in the next slide, I'm going to give you a little orientation of how to do it in a 3-dimensional approach. And once you complete ablating the lesion, again, it's important to do endoscopic and endosonographic examination of that area so that you don't have any adverse events. And we can talk more about the technique later on. There are more nuances to the technique as you start doing that. There is a learning curve to it, at least 5 to 10 cases before you're very comfortable with it. So this aspect of 3-dimensional ablation, EUS is essentially 2-dimensional, but remember that the cyst is 3-dimensional. So once you have the RFA needle in the cyst, depending on the location, your first direction with the elevator is along the long axis of the cyst, as shown in that first picture. And at each point on the axis, you have a three-dimensional approach, which is by rotating your body axis. So at each point along the axis, you rotate your body axis, you have a different ablation point. Yes, at some point you will not see the needle as you rotate, but you know you're still in the cyst and you're going to apply energy. So in that way, you cover the entire cyst because these are large cysts, you would have aspirated them. So there is a lot of space inside to aspirate. Now going on to a clinical trial. This is the first US clinical trial looking at EUS-RFA in brass duct IPMNs. And in all cases, diagnosis was established by endomicroscopy and next-gen sequencing. Just in one patient, we didn't do endomicroscopy. Otherwise, all patients had endomicroscopy and all patients had NGS. We used a very sophisticated technique to measure cyst volume. The way IPMN works after ablation is that if you take a balloon and you put a pin in it, it'll be in multiple pieces. So similarly, IPMN after ablation, it kind of shatters into small cysts. Now, if you just ask for radiology for response, if you look at that area, they will say, oh, complete ablation. And that's what most studies have done. In reality, though, you have to measure every piece left in that area. So we use this technique where it used a computerized region of interest marking, and we tabulate every small space left, and we give a total volume. So in terms of response, we have volumetric response, and then you have molecular response. For volumetric response, since it's a highly sensitive measure of the volume, we define complete response as more than 90% and partial response as more than 50%. And again, as I said, because IPMN does fragment, it necessarily doesn't fragment, but that's what's left after ablation. The reason to be highly sensitive about this is every tiny bit of IPMN left does matter, and you have to document it in your research results. Now, in terms of molecular response, it's either complete absence of KRAS GNAS mutations. We are also checking variant allele fraction, which is the proportion of specific mutation relative to the entire DNA burden in that sample. So we also defined complete response as more than 90% decrease in this variant allele fraction in the cyst aspiration post-ablation. Now, we couldn't aspirate all the cysts because when you have almost near complete volume response, there is nothing left to aspirate, but we can only aspirate in those cysts where they had some volume on follow-up imaging. Now, we define something new called a clinical response, which is either complete molecular response or complete volumetric response. Now, this could be perceived controversial by some reviewers because we really don't know what complete molecular response is. We don't know what will happen in the long term if some of these molecular markers reemerge. But at least for now, we define this clinical response as either complete volume response or molecular response. So in this study, we screened 110 patients, and then 25 patients underwent RFA. And in these 25 patients, there were 30 branch duct IPMNs, and the 30 IPMNs underwent a total of 41 RFA ablation sessions. In terms of subjects, 25 subjects, and the mean age 74 years. And if you look at the comorbidity burden, the mean Charlson comorbidity index was 5.9, indicating they were high risk for surgical procedures. In terms of cyst characteristics, 30 branch duct IPMNs, 80% were multilocular. The mean diameter was 4.6 centimeter. This is perhaps the highest mean diameter of IPMNs treated. Generally, in the chemoablation studies, the mean diameter is about 2.6, 2.7 centimeters. So these are fairly large IPMNs. And 70% of these were in the head and uncinate process in the pancreas. More cyst features, more than 93% had more than 3 centimeters in size, and 50% demonstrated a growth of 2.5 millimeters per year. 7% had at least one Kyoto high-risk stigmata. And in the 87% who had either KRAS or GNAS mutations, 10% had high-risk mutations. All patients who underwent endomicroscopy demonstrated papillary structures. And overall, 33% had either one Kyoto high-risk feature or cumulative more than 3 worrisome features or high-risk mutations. In terms of RFA, I had multiple variables, but I kind of trimmed down to what's important. The mean RF applications per IPMN was 14. The mean duration of RFA per IPMN was 5.2 minutes, and about 30% underwent a second session of RFA. And here are some examples. You have a complex cyst here in the head of the pancreas, which is multiseptated. It's about 3.5 centimeters, axial and coronal views. And post RFA, 3 months later, we see complete resolution. Of course, I'm showing you the complete response case. So, but here is another cyst. And this is kind of where you kind of leave a fragment. So here is a cyst of 4.5 centimeters, fairly unilocular in appearance, underwent RFA. And you see that there is a small fragment left behind right there. So, so you got to count all those small fragments left behind. And sometimes you could have more than 1 or 2 fragments. So if it's the complete response is only if we define it as more than 90% when you tabulate all the volume. So looking at overall response, this is a mean follow-up of 1 year with still studies ongoing. So volume reduction, complete response in 39%, a partial response in 79%. Molecular response, again, in those who underwent repeat aspiration, provided we had sufficient volume to aspirate. In those, 88% had complete molecular response. And if you define clinical response, overall, 82 persons, 23 or 28 branch duct IPMNs had a clinical response in this IPMN subset with a 4.5 centimeter mean diameter. We looked at multiple predictors of treatment response, and I've listed all those predictors there, but 2 variables were significant. One was the duration of RFA, that's 5.4 minutes versus 2.7. When we did a ROC curve analysis, The kind of sweet spot was 3.5 minutes, beyond which we didn't see more improvement or more complete response. But this may change as we do more cases and there is more prospective data. And unilocular cysts predictively achieved higher complete remission compared to multilocular cysts, but a majority were multilocular in this cohort. The most important discussion is adverse events. So we learned a lot from our adverse events. Overall adverse event rate of 12%, that is 5 of 41 sessions. Here in this specific case, we had a diurnal perforation in the bulb. The ice bath melted. We took us a little time to really align ourselves before we did the RFA. The ice bath came into the room at the start of the case, and we didn't realize that the ice bath had melted. So the water is not cooling the insulation jacket. And here you can see 2 needles. The needle at the bottom is the one we used in the case, and you can see the insulation is completely charred. So you have a long 4-centimeter needle exposed. So it caused a diurnal perforation, also caused pancreatitis. So we were able to manage this non-surgically, but the key learning point was that we included ice bath in the timeout, and also middle of the procedure timeout kind of thing, check on the ice bath. We submitted an IRB amendment. It was a whole big exercise because you had to be obsessed about the ice bath, that you have intact ice. Almost get 2 ice baths, have one as a backup in case. The other important thing is that once the ice bath is in and once it starts circulating in the cooling jacket, always get a feel of it. You can feel the water circulating. If you don't feel the water circulating, means something is kinked and the water is not flowing. So always be sure the water is circulating. We had an unexpected complication with the aneurysm of a branch of the gastroduodenal artery. The patient returned 2 days later. This is another example of not knowing what Plavix would do. Patient started Plavix the day after, and then patient came with a hematoma. It was managed by IR with embolization. Patient did well and was discharged in 3 days. We had a stricture over 3 months, developed a stricture, LFTs went up, we watched it, and eventually we stented even before the patient turned jaundice or got any infection. So we were able to successfully dilate with a covered metal stent. This is again because when you start doing RFA of large IPMNs in a 3-dimensional plane, you don't know what structure is closed, bile duct, pancreatic duct, or a blood vessel. A couple of patients, including the patient which I described earlier. So 2 episodes of pancreatitis, both were managed conservatively. And this last complication where we did RFA through the bulb, there was a counterburn in D2. So this is where we realized that we had to put a scope down and look all the way through. So we did the RFA, we were done from the bulb, and then the patient came back later with an ulcer in D2. It's probably because of the counterburn, because of the heat reaching all the way to the other side. And eventually there was a stricture and we had to put a lumen opposing stent to dilate the stricture. A key important point is the insulation jacket, where if you kind of jam on the elevator, you can erode that insulation jacket, and there you have a breach, and that will communicate heat to the duodenal wall or the pancreas. So many a times, if it's a long case, I stop, I take out the needle, make sure the insulation jacket is intact, and then go back and repeat the procedure. Of course, what we also realize is that we really don't need to apply that much heat as we thought we need to. Now that we know that at 3 minutes is a sweet spot, we can probably apply less heat and get equal response. So there are many unanswered questions. How many applications do we need to apply? The watts, what's the need for repeat RFA, the safety, which we talked about. We don't have long-term follow-up. We need to define predictors of response. This is a key thing. One of the key things, which again, one of the reviewers asked us is that, yes, you have some fragments of IPMN. How do you know one of those will not mutate over time and develop into a PDAC? So, and then the needle technology itself needs to evolve. And we are in discussion with Teo Wang as well. So again, to define response, so far we have volume, we have mutation analysis, and we are establishing durability. And there is this concept of immune modulation. Is there anti-tumor immunity which kicks in? So all these questions need to be answered. It'll take a multi-center prospective cohort to really answer these questions. So the final slide is that there is favorable volume and molecular response so far. We have gained important insights into procedural safety and technique. So EUS-RFA may offer a safe elective treatment option for high-risk surgical candidates with large branch duct IPMNs. And again, all this couldn't be done without the help from our study sponsors. And thank you.
Thank you so much, the consortium, for the kind invitation. So we have done a nice interview, a nice review so far on existing technologies. What I will try to do is show you what is cooking. We may be just scratching the surface with regards to what we might be able to do from an interventional standpoint. We have been doing well from a diagnostic standpoint, but we have the organ in access with EUS. So we may be able to do way more from an interventional standpoint. A good analogy is interventional radiology. They began with biopsies, but now they are doing way more from an intervention standpoint. Jorge and Som has done a good review on the chemotherapy-based things, alcohol and the paclitaxel. But there are still several gaps from an efficacy standpoint and from the safety standpoint. But these protocols have at least helped us identify who are the patients that are suitable for this and what should be the expectations. And some of the drawbacks from the radiofrequency ablation we have just heard, and from the heat generation that causes coagulative necrosis. But with regards to pancreas and GI in specific, heat may be not good, as we saw with some of the complications. So there are definitely several gaps that we may be able to fill. So let us review what are some of the technologies that are under development. So one is irreversible electroporation, where high voltage electric pulses are used to create permanent nanopores in the cell membranes and cause apoptosis. So this is so localized, and this is non-dermal, and it spares the vessels and the ducts and so on. This has already been used for pancreas solid tumors. There is an FDA-approved technology, so there is something that we might be able to use for pancreas cyst in specific situations. Some of the other things that are still in development are photodynamic therapy. So what they use here is a photosensitizer drug that is activated by light to generate reactive oxygen species and cause selective cell death. So this may be very similar to the fluorescein dye. Imagine when we are doing Cellvizio, the dye goes into the cyst, and we may be able to send a probe with EUS and cause very selective ablation. So this is promising for pancreatic neoplasms or pancreatic cysts and using in the EUS axis. And another exciting technology under development is cryoablation. These are image courtesy of John Bost, a brilliant engineer who has dedicated all his life on cryoablation-based technologies. So he has developed this EUS-based probe that can go into the EUS, go into the pancreas, and may have a potential for use in the pancreas cyst space. As we can see here, this probe goes through the EUS and can access the cystic lesion, and it creates a nice ball, like a sphere, of around 2.5 to 3 centimeter diameter, very localized, and the temperature is around -20. The core is -40. The surrounding temperature is -20 after just a 5-minute ablation. Some in vivo studies have been done in porcine models, and again, a very promising technology. Cryoablation is not unique for the GI space only, where we have used it in Barrett's, and we have seen the advantages, especially from an immunomodulator standpoint, because as the cells die in a more controlled manner, it releases the danger signals that attracts the natural killing cells and has much more potential effect and from cryoablation standpoint. And this has been used extensively in the oncology space. There are breast cancer-based probes and in pulmonary especially that are also ultrasound-based. So a lot of potential for use in the pancreatic cyst space as well. The next technology is the microwave ablation that uses electromagnetic microwaves that creates like rapid spinnings of the water molecules and creates like localized heat. The advantages is much faster and much localized, but can also be expanded to larger spaces, and there is no heat sink effect. And this has been successfully used in hepatic tumors and another potential for the pancreas cyst space. So we have seen the advantages of paclitaxel chemotherapeutic. It is already viscous, but pancreas cysts have those pores through which the drug could leak out. To increase the retention, there is this formulation in development, which is called the large surface area microparticle of paclitaxel. As you can see in the graph here on the bottom left, So this LSAM paclitaxel has much longer retention within the pancreas cyst. So this is also very promising that could be used in the pancreas cyst, especially that is larger and for much more effective use. So in summary, there are multiple evolving technologies with improving efficiency, efficacy, and safety profile. Technologies applied elsewhere, such as in oncology, pulmonary, and so on, that are ultrasound-based, has some applications in the pancreas cyst ablation. But there are still challenges with regards to use with endoscopy ultrasound from an engineering and technical standpoint. And as these are evolving, consortiums like these can provide the input and the feedback to the engineers so we can continue to develop these technologies. And there is a lot of potential to use hybrid approaches and also with AI-based applications. Thank you to the consortium, and this is our team. Thank you for everyone.
So we'll go ahead and get started. My name is Mandeep Sawhney. I'm the Director of Advanced Endoscopy at Beth Israel in Boston. And I've been asked to give you a general framework in which you can think about how we should be treating pancreatic cysts, so balancing treatment approaches for large IPMNs, ablation, surveillance, or surgery. So as we know, pancreatic cancer is a common cause of cancer death for both men and women in the United States. And it's been estimated that in the next 10 years, pancreatic cancer will be the second most common cause of cancer death. This is a meta-analysis that looks at what percentage of pancreatic cancers arise from pancreatic cysts. And the estimate is around 14%. But if you eliminate those two outliers because they recruited a very selected group of patients, like only those who were going to undergo surgery, the true estimate is closer to 5%. So in other words, even if we were able to magically cure all IPMNs, we're probably going to have only a very minimal effect on the morbidity and mortality of pancreatic cancer. The second point that I'd like to make is that the majority of patients with IPMNs don't die of pancreatic cancer. So this is a study of 725 patients with IPMNs that were followed for a decade at a single center in Massachusetts. The median cyst size is 25 millimeters. About 15% of these patients had main duct IPMN or mixed type IPMN. And you can see that only 21% of these patients eventually died of pancreatic cancer. So 4 out of 5 of these patients died of something else, cardiovascular disease, respiratory disease, or other cancers. And I'd like to particularly highlight this last group of patients who scored very highly on the Charleston Comorbidity Index. So these patients with comorbidities were 11 times more likely to die of something other than pancreatic cancer. So this really brings home the point that all these patients are not likely to benefit from treatment, and we have to have better ways of selecting which patients are likely to benefit from treatment of their IPMNs. The third point I want to bring up, and this is controversial, is that in patients with IPMN, is the risk of pancreatic cancer simply limited to the cyst, or is the rest of the pancreas also at risk of developing pancreatic cancer? So we have some studies, and these are mostly out of Japan, that suggest that even patients with small IPMNs, if you follow them long enough, will have a higher risk of pancreatic cancer. And in these studies, at least half of these cancers developed outside the pancreatic cyst. And then you have other studies that give us just the opposite result, suggesting that if a cancer hasn't developed in a cyst within the first 5 years, those patients are at very low risk of developing pancreatic cancer. And the risk of cancer in the gland outside the cyst is equivalent to that of the average population. So obviously, if the former is true, then that suggests that if you did local therapy for IPMN, that would only get half the job done. But we don't really know where the true answer lies over here. So let's step down to the level of the patient. And we all know that when we look at a patient, we will divide pancreatic cysts into high risk, intermediate risk, and low risk based on guidelines. The only 2 points that I'd like to make with this slide is one, that the accuracy in which we make those designations is relatively low. And then the second point I'd like to make is that the proportion of cysts that fall in the low risk category are probably much higher than what this diagram suggests. So I think there's very little controversy as to what to do with patients with high-risk pancreatic cysts. These patients should be expeditiously sent to surgery. And why expeditiously? Because this study suggests that if you wait for demonstrable demonstration of invasive cancer, the outcomes drop precipitously compared to if you were to operate on these patients early on. And I think there's also good agreement that patients with low-risk IPMNs do not need any treatment. They should undergo surveillance. I should point out that we don't have any high-quality data that suggests that surveillance really improves outcomes, but that's standard care. And the question is, patients between these two groups, between the low risk and the high risk, is there a role for local therapy like we've heard about this morning? So this is a list of some of the important studies looking at local therapies for pancreatic cysts, and we won't go over each of them because they've been nicely talked about. The only 2 points that I'd like to make here is one, that there's a huge variation in the types of cysts that were recruited into the study. So you can see that in some studies, only 12% of cysts are mucinous cysts, whereas in other studies, 100% of cysts are mucinous cysts. So it becomes hard to interpret the results. And then similarly, there's a big variation in the response rate to these pancreatic cysts. I think this is an important study. I heard the senior author present this data at DDW yesterday. This is a propensity match score. This is not a randomized study, so there's still some residual bias in the study, but these are patients who underwent EUS-guided ablation. Most of these are treated with ethanol, and it compared this to a group of patients who underwent surgical resection for their pancreatic cyst. And you can see that in the EUS group, there's much lower adverse events. The likelihood of readmission is much lower compared to the surgical group. The risk of developing diabetes 6 months and 1 year out is significantly lower compared to the surgical group. But then the surgical group does much better with regard to complete resolution and low rates of response. And this really begs the question as to whether IPMNs are going to go the way of Barrett's esophagus with dysplasia, in that initially we offer endoscopic therapy to these patients, and then those who fail endoscopic therapy may be candidates for surgery. And then we have several questions that we need to answer before we accept this form of treatment with regard to response with endoscopic therapy. And the first question is, how durable is a complete response? At least in some of these studies, it seems that if patients have responded, the likelihood that their cyst will reoccur is fairly low. But the question remains as to how good is radiology in making that determination of a complete response, and are we leaving microscopic dysplastic tissue behind that may later on develop into IPMN, and can we ever stop surveillance for these patients? We're fairly size-focused on pancreatic cysts, and the question is, if a cyst has a partial response, does that mean that we reduce the risk of developing pancreatic cancer in the future? And instead of being so size-focused, should we be looking at more DNA markers that Dr. Krishna has shown, and that might be a better marker for treatment? So I'd like to end by saying that in 2025, we have only 2 standards of care with regard to pancreatic cysts. We either have surveillance or we have surgery. It's really exciting, and it's a very rapidly developing field with regard to endoscopic management of pancreatic cysts, but I think that still should be done within the confines of clinical studies. Thank you very much.
So we'll go straight into endomicroscopy description of a papillary structure. As shown in the histopathology image, the papillary structure is characterized by an outer epithelium and an inner vascular core. The darker appearance of the epithelium is due to nuclei, which appear dark on endomicroscopy. Although the resolution doesn't match that of histopathology, the key benefit is that we can examine most of the intracystic epithelium in real time in a pre-surgical scenario. And if you remember the slide where I showed, there is a 3-dimensional approach to EUS, meaning that once you're doing endomicroscopy, once you are located in a specific site within the cyst, do not forget to rotate around your body axis to get additional imaging from the other parts of the cystic lesion. So again, the probe is going to disappear from your EUS view, but then you'll be capturing video from other parts of the cyst. So what I've learned during this process of endomicroscopy and RFA is that EUS is three-dimensional, and you should not forget that when you target these larger cystic lesions. And interestingly, though, in cardiology, they have a transesophageal echocardiogram, which is a three-dimensional probe. Essentially, the probe diameter is not bigger than what we have, but computationally, it gives you a three-dimensional rendering. And I'm surprised that we don't have one in GI. And for the industry people up in the back, this is something to really innovate. It will help us quite a bit. So in terms of endomicroscopy detecting advanced neoplasia in IPMN, the variables are quantifiable. And based on that model, we were able to kind of initially quantify, then build an AI model. So in the top panel, you have IPMNs with low-grade dysplasia. You have a single layer of cells with a monolayer of nuclei. And correspondingly, you have endomicroscopy, which is a really thin translucent layer. Now, at the bottom, you have high-grade dysplasia. It's basically you add multiple stories to the building, which is stratification of cells and nuclei. Now, we have higher grades of dysplasia. Correspondingly, in endomicroscopy, you have a thicker, juicier, darker epithelium indicating higher grades of dysplasia. Some more examples. On the left, you have low-grade dysplasia, where you have flat, thin epithelium, more translucent, and the papillae are smaller. In comparison to that, as the dysplasia progresses, epithelium is larger, thicker, and then, in fact, you get obliteration of the inner lamina propria. Now, when we go about, in the field of radiofrequency ablation or chemoablation, in the select patients where we're going to pick for ablation, it's critical to risk stratify what we are ablating or know what we are ablating. At least at this time, what we're advocating is that we ablate the low-grade dysplastic lesions only. The reason to be careful about high-grade dysplasia or the lesions with high-grade dysplasia is that in case they have adenocarcinoma inside, you're going to take that patient from a high-grade dysplasia and convert them to a metastatic malignancy. Because RFA or even putting a 19-gauge needle, where with RFA, you are actually staying there for some time. So we don't know the outcomes of RFA if there is cancer already inside. So here are multiple endomicroscopy videos. So as you start learning endomicroscopy, it gets to be challenging. The patient is breathing, the diaphragm is moving constantly, and these papillae, to complicate matters, are free-floating structures in a fluid media. So for the human eye, till you are trained with enough cases, it gets very challenging to judge the level of dysplasia. You may have to kind of pause the video, scroll frame by frame, and then kind of get to understand the dysplasia. But as you get to do more cases, when you're doing the case, you can, right after the case, you will know whether this is low grade or high grade as you've done more cases. But for now, because of these problems, we developed the AI model. And we call this nCLE AI, which is AI-driven image analysis to assist in interpretation of EUS endomicroscopy. We had an index manuscript about 4 years back. We kind of used a smaller patient sample, and so also we used edited videos. But over the last 4 years, it's been a slow and long process. We have developed the full AI model, where here you can see that the middle panel is AI, where it picks up the papillary structures in real time. And then further, it can risk stratify these papillary structures. So here is the model which we have right now. So if we start with the endomicroscopy video and you feed it to the AI, the nCLE AI, the first thing is it breaks down the video into individual frames. Then it'll pick up all the frames with papillae or epithelial structures. It'll reject every other frame. And subsequently is the frame level classification. It'll classify every frame as mild degree, moderate degree, or advanced degree of dysplasia. And then from this frame level classification, it uses logistic regression modeling to give a case level classification. There is a very specific reason why we devised it this way for now, because when you have multiple variables, because solving a puzzle, low grade versus high grade, it's like that jigsaw puzzle. You have multiple pieces and every piece matters. So with this modeling, you can add the Kyoto guidelines, you can add cyst fluid molecular analysis, you can add MRI data, MRI radiomic data, and then you can get a much better classification with the model. So here we had about 16 observers across the world. We provided the observers about 60 endomicroscopy videos. We compared that to the performance of AI, And later we provided both humans and AI, all the Fukuoka variables, and we got a final classification comparing, pitching the battle between humans and AI. So when you compare just looking at the endomicroscopy video for dysplasia classification as low grade and high grade, humans generally all across about 58% sensitivity, specificity, and accuracy. Comparatively, nCLE achieved a higher sensitivity, but the specificity was a bit compromised. But what we saw was interesting was that once we added the Fukuoka variables, the human performance went up a little marginally, but the AI performance with the combined model went up significantly, reaching a fairly well-optimized sensitivity, specificity, and accuracy. Now, once we did that analysis, this was before the Kyoto guidelines came out. And once the Kyoto guidelines came out, we added Kyoto variables to the nCLE model. The green bars show the performance of Kyoto high-risk stigmata. As you see, generally it has low sensitivity, high specificity. But then when you add AI and Kyoto together, there is a better balance of sensitivity, specificity, and the accuracy was a little more optimized at 83%. Of course, there is room to improvement as we add more data as shown with the molecule or with MRI radiomic data, which we're working on right now. So if you take this entire scenario of all these multiple variables, the pieces of the puzzle, which lets us risk stratify IPMNs with high accuracy, you have all the clinical variables, and then you have endomicroscopy, molecular analysis, and subsequently, if you add all the other variables and develop the integrative AI model, potentially we can host it in a central server, and hospitals can, in real time, assess the risk of these lesions with all the clinical data. Now, why is it so important? Because again, it comes back to that we should not ablate the wrong lesion, meaning that very extremely careful about those IPMNs with high-grade dysplasia, because if they do have high-grade dysplasia, they will hide malignancy inside somewhere. And we have to be very careful in establishing the risk profile of the lesion which we're going to ablate. So generally what we're doing right now at our institution is that if we have a low-grade lesion, given all the parameters, you have endomicroscopy, molecular analysis, Kyoto variables, and then we have a discussion with the patient. Because of our experience with endomicroscopy, we are very confident with it in terms of saying it's low-grade or high-grade. So once we have all the variables and we do endomicroscopy and we find that it is generally a low-risk, low-grade lesion, very flat, translucent epithelium, then we are confident in navigating the next step, which is ablation in the right patient who has got high surgical risks. So in conclusion, there is significant amount of intra-observed variation, which can potentially limit endomicroscopy-guided dysplasia classification by humans. To solve this, we developed the AI model, and the model is getting better and better year after year. And what we have found is that wherever the AI model kind of doesn't perform, the Kyoto variables synergistically work with the AI and improves the classification. That was kind of a revelation to us. And these findings do have significant implications as we move further in highly accurate risk stratification of IPMNs.
Okay, good morning. I want to thank Dr. Krishna and the consortium for inviting me. We're going to switch gears a little bit and talk about the financial aspects of more novel therapeutics in pancreatic cysts. For those of you that have not started endomicroscopy, just to give an overview in terms of capital costs, what you're going to have to put in your institution initially to bring this on. For your processor, the installation, your staff training, all the staff support, that's going to run in the 200,000s range. Can't give exact numbers because it's going to vary institution to institution. And then using the AQ Flex probe that actually performs your endomicroscopy is just under $11,000. But remember, you get 10 uses out of each probe. It's important to remember, and this is sometimes a struggle we're finding more now than ever with financial constraints at our institutions, that this can be hard to argue because your capital costs don't get incorporated into your patient billing. But I'm doing a walkthrough of some efforts you can do to work with your VAT committee and your institutional leadership. There are other potential opportunities to bring Cellvizio if you're not able to do a full flat purchase. They have, Mauna Kea offers a leasing or pay-per-use option. So you will have an initial upfront cost for the process of the staff training and your support, but the equipment itself is owned by Mauna Kea. It is important to note with the lease, there's no minimal requirement. You just lease it, you pay as you go, and you use it as you need it. When it comes to radiofrequency ablation, I'll tell you, when we have previously discussed about the needle that's used, that's approximately $3,000 per needle. In terms of the generator, that's about $50,000, but they do also offer some lease options, as well as some different placement options. One way we've used this and try to optimize the cost is our interventional radiology colleagues that are just a floor above us have the RFA generator that's compatible with this. So we're able to coordinate with them if we want to start using that. So that could be something to think about if you're wanting to look at a more cost benefit to your institution. This is kind of the money slide here, pun intended for this talk. It's really imperative you understand the coding for this. Many of us use Provation for our procedure documentation. Depending on the version you have, you may be able to select the coding and billing yourself. The version we have, we do not. And that's been a lot of challenge with working with our coders and our charge masters. Mauna Kea has been really wonderful helping us with that, as well as Taewoong trying to make sure you know the right CPT codes to use. This is a busy slide. I'm going to walk through it. The biggest thing is you are going to have two codes to use with Cellvizio. The first is 43238. You do not want to use the 43242. That's another alternative EUS that's actually a lower facility payment fee. So you really want to get the most bang for your buck. And then you want to use the 43252 to capture the endomicroscopy portion that you're doing. When you combine these two, the payout is just under $4,000 for the facility. Something just happened on the computer. And let's pull. Okay, thank you so much. And then you also have to think about the RVUs are additive. Now, again, unfortunately, with the multiple payment reduction fee, you won't get the full 4.2 plus, 3 RVUs. You're going to have that second procedure code that's about 50%, but it still is additive to just a standard EUS. So also, if many of you have RVU productivity as part of your salary or bonuses, this is additive, which is nice. And then interestingly, if you have multiple physicians that perform endomicroscopy, like where I'm at Moffitt, there's actually a separate code just for interpretation. It is only if you have a separate physician than the person who's performing the procedure. And this just gives an additive physician fee and about 1 RVU. When it comes to your radiofrequency ablation, there are 2 potential EUS codes you can use. There's 43237 versus the 43253. You can see there is some RVU difference, but the facility fee is the same. You also are going to have 43270. That captures the actual ablative part of your procedure. So that's another 4 RVUs. So again, you can see these are additive. Even though you get the 50% reduction for the second procedure in combination, you're still adding to what a standard endoscopy or endoscopic ultrasound would be. One thing you may notice is I do have some arrows here that's just reflective of changes from 2024. And these are usually Medicare national averages. Please keep in mind your private payers, it may actually be higher. And this is just showing us some of the changes from them. Again, just reviewing when it comes to the RVU productivity. And that is something that I've used to help advocate for this because, all of our institutions want us to do more. This is one way you're doing more without having to schedule another potential procedure in there. All right, so this is where I think there's a lot of helpful tips and tricks if you're trying to bring this technology to your institution. In talking with a lot of colleagues and our experience, we're having to fight more and more of a battle to really argue for why you need to spend money to get new technologies in. And if you think about it, the way I've argued is they just make both financial and business sense for an institution. We've all already talked about that patients now more than ever are desiring non-surgical interventions. We have previously just demonstrated there's actually a cost savings benefit when you use endomicroscopy and cysts larger than 3 centimeters, and that comes from preventing at least one unwarranted pancreatic resection. So this is older data, so the numbers are going to be different now, but that's a cost savings of over $400,000. Of course, we see as patients, they will often require more than one procedure. That is very nice for an institution to look at, where they see someone that's coming back and will require additional interventions or diagnoses. And then, as we mentioned, that's another reason it's really important that we understand the financial aspect, particularly our CPT and coding. Another great thing, if you have other specialists in your group that want to use these technologies for other disease sites, that can also be an argument for, the capital costs may not look as bad as they really are because we're going to get it used across different areas. So, for example, for endomicroscopy, they've demonstrated use to better diagnose dysplasia in Barrett's esophagus. They're using it in IBD surveillance. More recently, there's been a lot of exciting things in terms of food tolerance testing in irritable bowel syndrome patients. In terms of your radio frequency, I think we've already heard from our other experts that it's not just for use in pancreatic cysts, you're seeing it in solid pancreatic lesions. And then something important, a lot of this is common sense to us, but many of our administrators don't think about it. They look at cost or earnings as a single entity, but really with us and managing pancreatic cyst patients, there's a lot of downstream revenue. And so you have to bring that to our attention that we're going to be bringing money to different areas of this institution. And that includes lab work, especially with our patients that have ongoing surveillance. Also with your surveillance, you're going to have cross-sectional imaging, particularly at that facility, because many times if you have them go to more local or community, it may not be as high quality and not as accurate for that. They're going to undergo genetic counseling and testing. They're going to be evaluated by our surgical colleagues. They may get a possible resection. And then you have the opportunity to really develop a Pancreas Cyst Center. My colleague, Dr. Mock, did that at Moffitt, called the Pancreas Interception Center, along with one of our HPB surgeons, Dr. Denbo. And that's because we have a really high volume, and we've seen that overall nationally, the volume of pancreatic cysts is increasing. I want to thank you all again. Hopefully that's great information. I want to thank my fellow PIC colleagues, Dr. Mock and Dr. Capel. And these are all of our colleagues in our multidisciplinary clinic. Thank you.
I would like to take a moment to acknowledge our generous sponsors. Their support has been instrumental in making this meeting possible. Please join me in thanking our gold sponsors, Mauna Kea Technologies, Taewung Medical, Boston Scientific, Medtronic, Fujifilm, and AbbVie, and our bronze sponsors, Olympus, Nanology, and Amplified Sciences. We are grateful for this ongoing commitment to advancing education and research in pancreatic diseases.